So we want to, through the NHIN, support not only kind of the nationwide exchange, we also want to support the local providers. We anticipate that different kinds of providers and different kinds of networks will, again, require these different levels of services, policies, and standards to support that. Ultimately, we hope that if we have this kind of infrastructure out there, that there will be significant benefits that the American people and patients everywhere will benefit from. It provides benefit for federal agencies and healthcare organizations in the sense that it provides a way of exchanging information, and certainly within the limited production environment. The single data use agreement provides a way of having everybody agree to the same set of principles for data exchange. Certainly, having common infrastructure reduces costs. We hope that it will deliver better health care diagnoses and faster benefit decisions when it comes to insurance. And ultimately, having access to and the ability to control some of that information from the patient's perspective, I think empowers them to be able to be more participatory in their health care. For providers, certainly the NHIN can help support meaningful use and help providers who are interested in some of the monetary incentives to qualify for those by using some of the infrastructure that we have within the NHIN. We believe that it will help coordinate care between some of the private and governmental healthcare providers and aid in federal, state, and local agency responses to things like public health emergencies and disasters and pandemics. We need to be able to have the ability for information to have some degree of liquidity, to be able to follow the patient wherever that patient might be. Ultimately, we want to, and we always reiterate this, to make sure that the healthcare information exchange is reliable and secure. Privacy and confidentiality are important tenets that underlie all the things that we do. We hope that this communication will make the experience for patients to be better, reduce medical errors and unnecessary costs. We had a discussion earlier in the previous hour about the need for sharing information to reduce excessive testing. We hope that it will speed diagnosis and the processing of disability claims. Certainly there are work underway with SSA and others to help use this infrastructure to support that. And ultimately, by creating a set of standards with regard to services, standards, and policies, that will eliminate the one-off homegrown solutions and that everybody can kind of work together, pool their resource, and make sure that we create something that is beneficial to everybody. And will enable exchange not only within those local communities, but much broader than that. So when we think about how we're going to get to this notion of kind of accessing comprehensive patient information and data, being able to do real-time surveillance of the quality and health of the citizens that are out there, we need to kind of get there in some way. And so incrementally, we believe that we need to build from a foundation and then add new functionality. Part of the HITECH Act allows us to have multiple points in which we can incrementally add and raise the bar, if you will. We like to think about this as an escalator, that if we can get people on, we can kind of carry them up that escalator to the goal that we have of having this comprehensive data liquidity. Now, one of the things I think that's always helpful is to take a look at what we do now to exchange patient data between providers and between providers and patients, or between providers, and understand that these are the basic kinds of functionality that we need to support as we move forward. So if we want to exchange information, the first thing that we need to do is we need to take that information and we have to put that in some form that people can read and they can look at. This means that we need to define vocabulary, document, and messaging standards for what that piece of paper looks like and what that envelope that it goes into looks like. And by doing that, those are part of the things that become important in, say, the interim final rule on vocabulary and messaging standards that we have. Once you have that, you have to figure out where you're going to send it. And so right now, you might look up a person's fax number, or you might look up their address in the phone book. But we need to have electronic ways in which electronic healthcare record systems and providers can take this package of information that's stored electronically and find out where it needs to be sent. We have to be able to find the providers and figure out how they like their information to be delivered at what location. We also have to make sure that it's authenticated and that there are certificates. So we sign these letters so that we know that it came from the person that we thought it came from. And that becomes another thing that we need to be able to include, the ability to authenticate the information that gets sent. We have to have some way to route it. So if we're sending a letter, we have the post office that can help us with that. But we need delivery protocols. We need to have ways in which the people on both ends know how to establish a communication channel and then transmit that information in the appropriate way. And finally, it needs to be secure. We need to make sure that the package arrives unaltered on the other end, and that there isn't somebody who has opened the package and replaced the letter or changed it in some way. And all of this has to help happen within a fabric of trust. We have to know that the person sending it has the right intentions in sending that information, and we have to know that the person on the receiving end is going to be a good steward of that information as well. The thing is that as we think about the Nationwide Health Information Network, those become foundational components of everything that we do. We need authentication and certificates. We need vocabulary document messaging standards, delivery protocols, directories, a trust framework, and security. And if we can establish those things, we can, in an electronic way, replicate the way in which people communicate now around healthcare information. So we get that kind of exchange that we're really looking for. So where are we now? The vision of the NHIN has been officially endorsed by the HIT Policy Committee, and ONC is developing a strategy that is trying to look not only at this limited production, but this lightweight version that takes those 6 foundational components and provides that as a way of supporting our work. We are working right now to examine what is the essential components that we need for exchange, and creating sort of this lightweight on-ramp that will allow for providers and consumers to exchange information in a meaningful way and do so quickly and with sort of the limited amount, or without having too much technology overhead. We've been gathering input on how to achieve this vision and focusing on real needs and values. So you guys are the first to hear about this. We'll have a lot more information to say next week, but we are starting an initiative called NHIN Direct. And this is the set of standards, services, and policies. We haven't changed the definition of what NHIN is, that enables simple, secure exchange of health information between authorized care providers. This is an effort that is driven in large part by the NHIN Working Group that has charged us with extending the NHIN to support a much broader set of participants and providers. And the goal here is to provide a simple, standards-based, widely deployed, and well-supported method for providers to securely exchange health information that uses the internet. We believe the kinds of things that we want to be able to support include things like laboratory results from the laboratory to the provider, medication reconciliation and provider summary care records and discharge for each transition of care and referral between providers, and supply the foundation for support of patient engagement and for public health. We believe that this is an important next step in the sense that it complements the current limited production exchange. And ultimately, if we believe that there is going to be this heterogeneous and multiple ways of exchanging information, we need both this NHIN Direct as well as the current NHIN limited production exchange to support different kinds of information exchange in different use cases. So the question that we're asking is, what are the policy standards and services that are needed to empower consumers? What are the next steps that we need to do? And this is going to be one of the challenges that we have. We've got a series of work plans that are already in place, and we hope to engage a very broad set of consumers, industry, public and private partners to really help us describe what this NHIN Direct should look like. What are the standards and resources that we need? What are the enabling organizations that are required? And what are the trusts and services that we need to be able to be successful with this? It is critical to our success to make sure that these are compatible with the existing NHIN exchange. And those things don't go away. It becomes a really important part of what we do. So with that, I want to turn things over to Mariann, who's going to talk a bit more about the limited production exchange. Again, a key component to making sure that all of these pieces fit together and they all play nice.
Well, thank you, Doug. And I will ask you to drive the slides here, so I won't have to reach. Well, good afternoon. I wanted to spend just a few minutes shedding a little light on some of the NHIN production activities to date. I think Doug painted a picture of that the NHIN is really intended to include a broad spectrum of information exchange models, from the simple exchange between providers in support of meaningful use, and spanning really across a multitude of needs to robust exchange. And actually, ONC, as many of you probably know, a number of you in the room have been directly involved in these activities. ONC has been actively engaged over the past several years, really building initial sets of capabilities for nationwide exchange. And there actually has been significant focus in three particular areas: making sure that there are technical components available for exchange in the form of specifications and standards and testing mechanisms. There has been work on the federal side to develop a gateway called Connect. That's an open source software implementation of the NHIN specifications. And there actually is a production exchange today that's taking place today that is using those technical mechanisms and a foundation of trust for exchange. So we wanted to share a little bit more about what's going on with these activities and how they relate to the broad spectrum. Connect really reflects how the federal agencies responded and how they wanted to engage and connect in the limited exchange. So Connect is actually a software solution that was developed through a collaborative effort, leadership from FHA, the Federal Health Architecture Group, that really serves as the gateway that federal agencies would use to exchange data in the NHIN. And based upon those experiences, that solution was made available to the open source community to allow the private sector to also engage. And Connect is really, I'm sure many of you have heard about it. They've had tremendous success to date because of the intensive collaborative effort that they've had. There are a number of agencies that are in production today using Connect, others that are doing demonstrations. There's a huge interoperability showcase at HIMSS that will feature probably, I think, 40 different demonstrations using Connect and NHIN specifications, just a significant body of work there, and also private entities that have expressed interest in using this as a solution. When we talk about the limited production exchange, what we're really talking about is the group of entities, private, non-federal, federal, state-level entities that have really come together, whether they've used a Connect as a solution or their own gateway, that they came together to really find a way to make data exchange work that would scale across geographies, across different organizational types, across disparate policy and technical frameworks. And this has been really an incredible effort. I've had the pleasure of working with the NHIN Cooperative, which is the group that really led the development of this. And it was about probably 30 different organizations, again, small, large, state level, federal entities, private entities that came together to find a way to make this work. Not only to come to agreement on a set of standards and specifications that they felt would work across these myriad environments, but to actually come together and develop a set of testing requirements and validation expectations that they would all mutually agree to, one common way of doing business. They came together to identify a set of criteria for trust, expectations for trust, for privacy, for security, on appropriate data stewardship. They have actually agreed to and have executed a common trust agreement that puts forward those expectations and codifies them in a contract. And really the mechanism around joining this limited production exchange was really established by the group as well, and having a mechanism to actually grant access by issuing digital credentials once an organization has proven that they conform to the specifications, they are a trusted entity, they will meet the terms and conditions. And there's actually a committee structure that this particular group is using to oversee their activities. Today, there are 5 entities exchanging data in production: the Social Security Administration, Med Virginia, VA, Veterans Administration, Kaiser Permanente, and the Department of Defense. And so data is being exchanged, live data, real systems, and it's in early stages of rollout. I think a number of the members of the NeHC Board of Directors were actually present when the demonstrations were made of this work to the AHIC in September of 2008. And we've made a tremendous amount of progress, and we're in production. And I think it speaks volumes to the commitment that these organizations have had to really find a way to make it work in a hugely what can seem a hugely complex and daunting environment, but it's actually very doable, and I'm hoping that over time you'll be able to hear directly from those organizations and their experiences and what they had to do to